Welcome to the PT and OT Connection podcast by Summit Professional Education, dedicated to helping PTs and OTs improve patient outcomes while earning continuing education credit. For information on earning CE credits for this podcast and satisfactory completion requirements for your state and profession, please go to summit-education.com or click the link of the course description in your podcast platform.
Hello and welcome to the podcast. Today I'm going to be talking about hip fractures, a really broad topic, and I'm going to try and touch on different facets of prevention, immediate rehabilitation, some surgical considerations, and then the long-term care, all the different places that we as therapists are involved. My name's Jason. I'm a physical therapist with the Medical University of South Carolina. I've been in practice for about 23 years, specializing in orthopedics. I work primarily in some of our outpatient clinics, fitness setting, general outpatient office. Still do work as well in acute care, inpatient rehab, a lot of the different places where we will encounter folks dealing with hip fractures, both on the preventative side, the rehabilitation side, and then long-term with balance training, strength training exercise, trying to reduce long-term incidents, long-term problems that can develop with this. Our outline for today, we're going to go over the incidence of hip fracture, mortality rates at first, cover some risk factors, both modifiable, non-modifiable, mitigation of those, therapy roles in those, the acute management of fracture when it does happen, surgical decisions, patient assessments, kind of what the medical team's going through and what they're planning and how decisions there, what they can do for the long-term outcomes. I'm going to cover the hospital rehabilitation phase and timelines and then criteria for transition to further rehabilitation. Go over the whole recovery timeline, how long it takes to regain strength, regain balance, trying to build confidence, and some best practice interventions there. And then the long-term prognosis, ongoing therapy, fall programs, fall recurrence reduction, all of those. Most of the things I'll cover today are based on some guidelines recently, both from the American Academy of Orthopedic Surgeons, the American Physical Therapy Association, the American Academy of Cardiologists. So a lot of guidelines, research that's gone into these to streamlining how we can most effectively handle folks here. It's estimated that there are over 300,000 hospital admissions just in the United States. And unfortunately for many of the folks that suffer a fracture in their hip, they can be fatal, both within the first few months, and all-cause mortality is rated as high as 30 to even 35% within the subsequent year. And usually that's a result of multiple reasons, but it's their premorbid status, medical complications, age, frailty, and then just general not getting a lot of mobility back. Maybe they already were at a fairly low level to begin with, and then it goes even further declines. There's a lot of fear, anxiety, pain that can happen here, and sometimes people don't get their confidence back. And all too common, the story is, you have an elderly woman, typically female, maybe early 80s, possibly some cognitive deficits, early dementia, already needing a little bit of assistance with care, maybe in a facility, assisted living, or living on their own. They suffer the hip fracture. It can be an accidental fall. A lot of times it's osteoporotic, the more pathological kind of fractures. And then just the subsequent weeks, months, not getting a lot of mobility back, and then they get into a later season of the year. It becomes, cold and flu season, and then they contract pneumonia, and that ends up they die. I've seen it happen, unfortunately, many times. I'm sure many of you have as well. That's what we're going to cover today is prevention, first of all. So what are some risk factors for it? Of course, those are pretty commonly known. It's more often females, certainly men, but it runs about 80% of females that develop osteoporosis. Caucasian, fair skin, usually smaller bone structures throughout their lives. There certainly can be some dietary things that go in there, reactions to medications, maybe ladies that have had to go through chemo, hormone replacements or lack thereof, things that change their bone density throughout their lives. As far as mitigation and reduction of the modifiable risk factors, of course, gender, um, ethnicity, body structure, those things, those aren't really modifiable. But there are a number of medications that are recommended. I mean, it can be all the way back to Fosamax, and certainly not without its controversy now. Some of the side effects, long-term things with that. It was used for a long time. The ladies would use different injections, are now recommended based on bone density. Prolia is a commonly used one. And that's the medical management. Of course, calcium, vitamin D throughout your lives. But the big one is resistance training. We know now, long axis bone stress, weight bearing exercise, walking with resistance. Resisted training with weights or with objects you can do in the home, but actually trying to increase the stress across primarily the hips, the femur being the biggest long bone in the body. Fractures mostly happen here in the wrist, the spine, the femur. So ways that we can load the spine safely and the hips as well in a weight-bearing kind of way for strengthening, whether it be incorporating weights throughout their lives is the key. And actually, I always like to say that the reduction of risk factors for osteoporosis should start with young girls, especially 15, 20, in your teenage years, 20s, 30s, starting then both with diet, recognizing if you are going to be at a risk. I mean, it's very easy to say, okay, you look at your mother, look at your grandmother, look at your aunts, look at their body structures, their types. Is there genetic things that's going to predispose you? And you start earlier in life, both with diet intake of calcium, vitamin D, healthy diets, and then regular exercise. And I'm a proponent of strength training for younger women. I work a fair amount of times in a gym here. We have a clinic inside of a YMCA, and I look around at who's exercising. And it's been nice to see the last few years more of an incidence of younger females, teenagers, even their 20s and 30s, actually doing some resistance training. Treadmills are great, stairmasters are great, ellipticals are great, but a lot of the prevention of these things long term, I think, comes earlier in your life and incorporating resistance training early and then maintaining it. So I love to see young ladies actually doing some squats, doing some deadlifts, step aerobics kind of things, but adding some weight to it. Walking is certainly great, but I think you need that resistance component, a little more weight that goes in there. And it can be, if you don't like gyms, it can be, hiking, but put a backpack on when you hike. Get a backpack, put some weight in it, maybe water bottles or whatever you want to use, but add weight to it. So you're adding a little bit of vertical compression, both to the spine and to the hips when you go walking or go hiking. So anything like that where you can be creative. It can be high tech, it can be low tech, to add a little bit of stress across the bones to help improve the density throughout their lives. So those are certainly some things that people can do individually as just general lifestyle components, general fitness. But maybe they get a little older and didn't start or didn't do a lot of those things when they're younger, and then maybe they're in their 50s, 60s, and starting to see some evidence on maybe some medical testing. Their T scores are dropping a little bit. And they're like, the bones are thinning, and what can we do? Again, it's never too late to start some resistance training there. This doesn't have to be super heavy. It certainly can be. I think it could be safely done with proper coaching, but you can still do resistance training then. Maybe your effect won't be as great as you started younger, but it's better late than never. And then you start to deal with balance components, delayed reaction times, ankle strength, hip strength, and just some general confidence in moving. Simple clinic exercises that we can teach people was sit to stands, balancing, heel toe stance, single leg stance, multi-directional kind of things. And these can easily be implemented in a clinic. They can be taught lots of ways to do it at home. If somebody's got a flight of steps, great way to work just on stepping up and down and making that exercises. Chairs, resisted things. I love to incorporate medicine balls, kettlebells, or any kind of a weight you can come up with at home. I routinely tell people you can do some lifting and carrying at home, again, with a backpack with weights in it. I'll take grocery bags and put cans in them. I'm carrying those. A lot of functional everyday things that don't require a lot of equipment. You don't go out and buy, fancy machines, things like that. Usually you look around your house, you can find some ways that you can add resistance there. And adding the resistance, and you can put things in one hand or both hands, whether it be kettlebells, weighted bags. You can put them in the hands because you want to challenge balancing. You can make them work on lateral stepping, stepping up and down, balancing things. Or you could go full on to, all kinds of balance master devices. There's all kinds of in-clinic things that we can do where they're appropriate to work on challenging their balance in multi-directional angles. One of the big things there, I think, though, is actually just instilling some confidence into people, both men and women, to make them a little more secure. Certainly, as things progress, as maybe the use of assistive devices, canes. I like to use the trekking poles for people as well. I think those are a great way that you can do balance, and you can be outside walking. They're sometimes for people I run into, it's maybe a little more socially acceptable to use those. They think it looks cooler and more European. If I have like a 60-year-old lady who she doesn't want to be seen with a cane, certainly don't seem to be a walker. I can think of a number of incidents throughout my career where I've suggested walkers to people, and the people would just flat refuse to use them because mostly they said it made them look old, and they didn't want to do that. So I can be sensitive to that. I think that we need to be. So sometimes the trekking poles, and they used to be more expensive, but now I tell people you can find them online for, $20, $25 a set, and I use those. One of them or two of them helps with posture. You're a little more upright. They're used that way. Walkers and canes people tend to stoop and lean over, and we want to have them, a little more vertical, weight bearing through the spine, and nice upright postures. So a lot of things that can happen there preoperatively. So there, to summarize that section, I'd say risk factors primarily include certainly age, low bone density, that's calculated with T-scores, bone density tests, and then a general impaired balance are the big three that are risk factors. So now we'll go ahead and say, unfortunately, the fracture has happened. What we do acutely with it. Careful to remember here that fracture is both a sign and a symptom of osteoporosis. And unfortunately, sometimes it's the first one where they define it, yeah, you actually have osteoporosis. I mean, you certainly have genetic factors, and people, ladies in particular, they know, grandma had these problems and my mom did, and kind of is a genetic thing in the family. And I always say I can tell just by kind of looking at somebody, I think they're going to be osteoporotic. They're going to be fair skin, small bone structure, maybe not real physically active, maybe not a lot of good muscle tone and muscle strength, a little, just kind of the little old lady you look at, you can tell. And you're afraid to do too much sometimes with the older ladies because you can tell this is, osteoporosis waiting to happen. So whether or not they had testing throughout their lives or were taking steps to prevent it, once they have the fracture, and depending on where it is, of course, that's usually both a sign and it's a symptom that, yeah, it's guaranteed. Sorry, ma'am, you do have osteoporosis. So now what happens? They're at the hospital. Typically, these injuries, they occur at home. They've fallen, and always the thing was, did the fall cause the hip fracture, or did the fracture cause the fall? Well, I'll tell you, most of the time it's this: the fracture happened, and that made them fall. Of course, depending on where it is, and there you can see, if it's a comminuted fracture of more the trochanter where they landed on it, you can see that. But if they spiral or they're intercapsular fractures, femoral neck kind of fractures, it's usually the fracture happened and that's what made them fall down. So now here they are in the hospital, in the ER. It's pretty easy to diagnose the fracture. The ER physicians, the EMTs, they already know it. Usually the leg will be retracted, externally rotated, and of course be severe pain. There will be a mechanism. And so what's going to happen there? So we start optimizing right away. At least what we have, and what most larger hospitals, and smaller hospitals too, have pathways, and it's pretty structured on what's going to happen here. Everybody's got their roles, from optimization, is there going to be surgery or not, imaging to confirm the diagnosis, orthopedic consults. We do them there right there in the ER. So we've got it there, and then the plan is made. What's kind of going through the medical team's mind here? So sometimes we don't know that. Where I am, we are involved a little bit in ER visits, and we get consults to the ER. Probably not on one of these cases because they know what's going on. But they're going to come in. What they're looking at is where's the fracture? Where did it happen? Is it the head? Does it involve the acetabulum? Is it just the femoral neck, or what they call intracapsular? So if you can remember back to anatomy class, where the capsule is and kind of goes around the, if you think of when you find your greater trochanter on your hip and kind of look, but inside that's the capsule. So kind of from the trochanter in towards the head, we call that intercapsular. And also, if you remember, that's a cancellous kind of bone. It's a little more spongy area bone, usually the weakest spot anyway. You get down into the femoral shaft, it's more dense. They'll look and see where's the fracture. So is it intercapsular or extracapsular? Sometimes they'll call those subtrochanteric. So again, the trochanter is kind of the definitive marker, and you look below it. And if it's more of a spiral or a displaced fracture below the trochanter, that's going to be managed a different way. So then what you look at, and okay, how can we manage to repair the fracture? And I guess the first question is even, are we going to repair the fracture? And that's where screenings go in initially. And a lot of it has to do with dementia, living and life status before that, comorbidities. Is this a patient who has a terminal cancer? And they've been going through chemotherapy and they're quite frail medically anyway. And then potential for functional rehabilitation afterwards. And then also putting them through the surgery and what's the benefit to it, because there are times where it's certainly appropriate to not do the surgery, to do pain management, and you even within palliative care consults, certainly talking with family members, loved ones, etc., to make the best decision of what's here. But more often than not, it's safer in the long term if you do some kind of a repair, even if it's just to make it so that the person can transfer more easily, and they're going to have some acute pain, but long-term pain reduction is better if you can repair it, even giving basic function where they're not completely dependent mobility, because of course if we do that, now you're setting them up for decubitus ulcers and systemic problems, and potentially sepsis in the future. And of course that's the thing they look at here too, because if you break the bone here in the hip, there's a fair amount of bleeding inside. So they certainly do sepsis screenings and start all those things. So that's what's happening there in the ER. Determining that, kind of making a long-term prognosis decision already. They're going to bring in orthopedics for opinions on that. Certainly going to talk with the family. Typically, this is a point where we get consults, usually physical therapists. We're going to be involved here. Now they're maybe in the acute care floors. This is a nice time to do some of the preoperative education if you can. What we get a consult on people with the fracture. It's actually part of the order set, so we get a consult to see them. Now, surgery may be later that day or the next morning. It's nice if you can go there to see them, at least visit with the family. That's a better time to do some of your preoperative training, preoperative education before the anesthesia kicks in, so we can discuss and kind of get the picture from the person, from the family, caregivers. What's the status at home? What's the living situation? What's the goal long term? And mostly you want to assess here cognitive status. Now, granted, they're going to be in pain, and there's going to be a lot of anxiety, but you try and figure out that stuff before they come out of anesthesia, and then you try and figure all those things out too. So we try and get in there preoperative if we can. So again, recommendations are that surgery would happen within 24 to 48 hours if it's going to happen. Multiple different things you can do here. Intracapsular fractures, so inside that capsule, femoral neck, head are most often repaired by a hemiarthroplasty is actually recommended. Certainly that matters if you have a fracture, if it's complex and it's where the shaft, the arthroplasty component is going to have to go down into the shaft, and it's going to be cemented, so you have to have pretty good bone down there. Remember, you're dealing with osteoporosis in general, so certainly if it's not going to be soft enough to hold it, then you would do pin and screws. But when at all possible, you like to do a hemiarthroplasty here. For some people, it makes sense to go ahead and do a total hip as well. All depends on the acetabulum, what's going on. But I'll tell you, functionally, if they can be converted into just a total hip replacement, because then you're going to have immediate weight bearing, pain is going to be a little bit less, and the function is going to be better if that can happen. So sometimes the patient's a little hesitant. They go, well, I broke my hip and now I have a replacement. We have to say, yeah, that's actually long term, it's better. You don't have the weight bearing restrictions, and the long run will be better for you. But of course, that's entirely dependent on the fracture and the bone density. If you have soft bones, it's not going to hold. So other types of fractures, if they're subtrochanteric, that's going to be done with either a sliding screw or a pin as well, because you have nothing to anchor the prosthesis to. So certainly the old over reduction internal fixation certainly has its role here. It all depends on the location of the fracture. So of course, if that happens, you're going to have some weight-bearing limitations and pain afterwards. And dealing with cognitive status, I often tell people and some other courses that I teach, one of your least favorite patients to walk in the room with is, your 85-year-old sweet little grandma, and she maybe has some dementia, and now she's confused and she's scared as well, and the family is scared, and we've put the pin and the screws in there, and her hip is stable and it's hurting, and then we come in, and our job's mobility and transfers, and we're going to be getting out of bed and doing all these things. Then you have to say, okay, you can only be touchdown weight bearing or non-weight bearing, and you have to use this walker and stand, and well, don't touch your foot on the ground, and don't put this down there. And it's just very hard to do. I will tell you, most of them go ahead and they put some weight on and they seem to hold, but you're going to have a lot more limitations there for 4 to 6 weeks while the thing heals. Again, you remember, you're dealing with an osteoporotic bone, which is soft anyway, and you have to give the thing plenty of time to heal and be thinking, long term, where do I want this person to be in 6 months, not just the first couple of days. So we don't get in a huge rush there for a lot of ambulation, although we certainly do as much as they can. So that's where some of the decisions are made. And then there's things that medically they have to do to optimize in both cardiac status, medications that they're used. The types of analgesia is the big one. I mean, we want to minimize any postoperative dementia, delirium. So whether it's spinal blocks or local things, and what are we going to do with some narcotics? There is a role for oxycodone and things still there immediately, but of course, we want to get off of those as soon as we can because of side effects. And it's what's called a multimodal analgesia. You'll see a combination of medicines used, both oral, intravenous kind of things that are used. Some local blocks, if they can do, it'd be more likely maybe a psoas type of block that's here. Some different types of spinal analgesia are actually not recommended here. You don't want anything where they're completely numb, because you don't want to affect motor function. You want to just do sensory blocks if you can, so they can be more sensory nerves and dorsal root kind of blocks instead of just full-on analgesia from a spinal. So typically, even like an epidural here, you would like to avoid. That has to do with motor function, and you want to. The idea, and we'll get to this with later, is we want to have these people up and moving, ideally same day as surgery. So we want to have motor function down. We want to have the muscles to contract. We want them to feel from the waist down. We'll manage the pain locally. We're going to be putting weight on this. We don't want to completely numb you with a spinal epidural either. But every decision you make, and I think you'll see it from this, is planning with the next phase of care, from the ER to what's next, the surgery decisions to what's next, what's going to optimize their recovery, getting them going. So now here we are. They've had the surgery. They're out of the recovery room, back into a regular room, and it's maybe a couple hours after the surgery. And then, where does the therapy start then? What's the role of nursing? What am I doing there? Well, a couple of things. First of all is, they've had the surgery. Now we want to, do DVT prevention, so venous thromboembolism prevention stuff. It's as simple as they're going to have the compression stockings on their legs. Sequential pumps are going to be there, but the big one really is, let's get the muscles moving. Let's get some flexing of muscles from the waist down, particularly the calf muscle. I like to do this actually resisted instead of just the standard old ankle pumps in the bed. I actually will manually resist it. I'll teach family members how to do it. I'll get a little piece of TheraBand and actually resist it. We'll just flexing the calf muscle on your own goes a long way. But again, the big thing is we want to get them moving out of bed. A recommendation is that they be mobilized, but all possible, on post-op day 0. So we try and get in the same day. It may be end of the day, 4 or 5 o'clock in the afternoon, and everybody's wanting to go home, but we get in there and go anyway and do it. Big recommendation that we do too is that we don't have nursing wait for therapy to come get them out of bed. We like to have anybody can be trained to mobilize them, get them out of bed, sitting on the side. Goal would be that after surgery, your next meal, whether it be your dinner or whatever, is actually done sitting up and out of bed. So that's kind of a goal that we have. Not always met. It's by no means a perfect world. It depends on timing and staffing, all kinds of things. But the goal is the earlier they can be mobilized. I'll tell you, that goes a long way in reducing fear and anxiety. To lying there in bed and just thinking about it. You sit on the side, and then they realize that, hey, I moved, and yeah, it hurt, but it's okay. I moved. I actually stood on it on the first day, and I was able to sit in a chair. And so I would tell you that decreases a little bit of that anxiety. This is going to be okay. It hurts like heck. It really does. But I stood up and I could support myself. The muscles contracted, and I've got this staff around me that's here to help me to get going. So of course we try and do post-op day zero. Bladder management things is a big concern here. Avoidance of Foley catheters, you'll see that. WIC devices that are in there, things like that we like to do, whether it be even just a transfer to a bedside commode, that kind of stuff goes on there. Okay, so therapies there. What's our assessments look like? Again, we try and do it post-op day zero. We even shoot for within 4 to 6 hours of surgery if we can be there. Now, if that doesn't time up right, it's going to be, first thing on. We're going to move in like first case the next morning as well. Because long-term, what the recommendation is going to be is on weekdays is we're going to try to do these people a BID frequency. I know a lot of things go into that, but we're going to try and offer at least twice a day to have them moving, doing some exercises in bed, sitting up, standing. We're going to head that way as far as we can. So where do we start? We like to start. We just go through an assessment. You have to check range of motion, particularly quad strength, glute strength, what kind of muscles you got flexing here. Range of motion to an extent, but it's not going to matter quite as much here. We're going to modify that stuff. It's going to be stiff. It's going to be sore, but are the muscles flexing? Can they bend? Can they roll a little bit? Can they get to one side? How much assistance they need in bed mobility? There's a lot of exercises you can do in bed. Rolling's a great one for the trunk and the torso. A little, kind of assisting with a little even modified bridge. You kind of hold their feet and just get them flexing their lower back, get them moving a little bit. We're going to sit them on the side. We're going to go through the Impact 6 clicks and just get an idea of where they are and start doing some scoring and planning based on that. Gait speed and velocity. So that might happen the first day. It might be that they stand and it's a pivot to a chair and you got that. But along the way, we're going to start doing gait assessments, of course, assisted devices. This is mostly going to be walkers when they do it just in the room. You can get 5 feet, 10 feet, 20 feet, all these kind of distances that are all planning for the next phase and where they're going to be. The further you can walk in the first couple of days, or you're more likely to be home sooner, of course, or in outpatient settings. And if you can't, then we make our discharge criteria based on that. A lot of it has to do with level of assistance needed. I mean, are you max assisted to transfer and even to stand, and walking 5 feet is completely wiping you out, or you're going to have a little longer term rehabilitation most likely than somebody else. So a lot of simple things that all of us have done for years that go into those. So what are we going to do with them? It's, this is based on guideline recommendations from the APTA, and to me, just it's more some common sense, but this would be daily structured. It's actually recommended that they be offered daily exercise, high intensity resistive strength, and that gets a little that gets a little tricky or controversial here. But what is high intensity resisted strengthening? Day one post-op hip fracture. Well, I would offer that it's not just quad sets and glute sets. It may be, but just pumping them, squeezing them. Now, what I even do here, and we'll talk later. We get into exercise prescriptions and talk about repetition maximum testing and all those kind of things that sometimes are thought about being just in the gym setting, or you do a 1 rep max test. And I ask people in courses, I'm like, when was the last time you did a 1 rep max test? Post-op day 1 or post-op day 2 on somebody, and you get kind of a deer in the headlights testing. But it can be as simple as how long, what's the actual strength they have right now? It can be as simple as have them do an isometric, maybe against pressure, something like that, quad set, but pushing against you, and then have them maintain it just as long as they can and time it, because exercise prescription, we want to be working to build strength. We want to be working at about 60 to 70% of a 1 repetition maximum, 8 to 12 reps, 2 to 3 sets. That's kind of the mid-range. There's lots of set rep schemes you can get into, but you're looking here, instead of just 30 ankle pumps and 30 glute sets, quick pumps, actually have them do 1 and time it. How long can they actually maintain a muscle contraction? And say it's they can actually do it for 15 to 20 seconds. Well, I kind of backtrack from that. So maybe you would do a glute set exercise, a quad set. And I'll have you just hold it as firm as you can, as long as you can, and I'll time it. And let's say you got to 20 seconds. then my prescription for you is going to be, okay, you held it for 20 seconds. Let's see, about 60% of that, we're going to say maybe about 12 seconds. So I'm going to have you try a few of those in a row. I want you to hold each one at least 12, 13 seconds. And so we'll go through a few of those. I'm shooting for maybe we can get to that first day, 8 of those in one set. You kind of assess how they're feeling. And that's the way you can take strength parameters and actually be sure that we're dosing them. I think across the board, I think in therapy, we underdose people. And I certainly think in this setting as well with some of these people, our bias is a bit to underdose them. Now, I'm not talking about, 20 repetitions post-op day 0, but in that first couple of days, so that first week, to look at and find out what's actually their maximum right now. What can they do? And that can be as simple as a time. If they can sit on the side of the bed, you can have them do just like a long arc quad lift. Maybe put a small weight on there and see, okay, can you actually lift 1 pound and how long can you hold it there? So I advocate timing it. We're probably not pulling out our handheld dynamometers there in the acute care setting, but I would encourage all of you to be a little more specific on exercise prescription and dosing. Not just 2 sets of 10 and you just flex and hold. I think flexing them is fine for circulation. I think just squeeze and pump and squeeze and pump, and thinking that is pumping blood, that's okay. But if you actually want to build some strength, you can start early, and I think we can be more specific in actually dosing that for people. So certainly that's some bed-based exercises, kind of warm-up things, base strengthening stuff. But again, what we mostly want to be doing here with all patients is strengthening for specific function. So what's the most functional thing that these people need to be able to do? Well, to move around and get out of the bed, for first of all, and then be able to stand at the side safely. So I'll start even just trunk rolling in bed, going side to side, modified bridging things, just starting there in the bed to move, because we want to get them as independent as we can with bed mobility. Make those into some exercises right there. It doesn't have to be just quad sets and hip abduction and open chain kind of things. Remember that the body functions closed chain. So maybe a lot of straight leg raises isn't the best thing to do. Maybe rolling to the side and then sit to stands is some of my favorite things to do right there in the acute care setting. Is I just do repeated sit to stand, up and down. We stand, we bounce a little bit, and we come back down, really incorporating weight bearing through the joint, muscle co-contraction, and I'll just repeat them. That's another place you can find what's a 1RM. What's their sit to stand? What can they do? Time it if you want. Like how many times can you come up and down in a minute? How much assistance do they need? Then repeat that, and maybe you got 3 of them there, so we'll do like 3 sets of 3 of just a sit to stand exercise. I would offer that that's better strengthening because it's a closed chain thing for them. It's muscle co-contraction, it's glutes, it's quads, it's everything working together versus just laying in bed and can you do 15 straight leg raises and 15 ankle pumps. So I'm all for getting their feet on the ground as soon as we can, as safely as we can, because that's the way the body functions, is standing. Transferring over, even as simple as a bedside commode. Again, I mentioned earlier we want to minimize the use of Foley catheters as best we can. They can have PureWick devices, but again, just we get to the bedside commode, or ultimately on and off the toilet is going to be better in the long term. Maybe simpler to use the Foley catheter. Some of the patients maybe want to do that, or it's simpler for us, it's simpler for the nursing staff, but it's actually better in the long run for the patient. Of course, these are typically women, and we know the longer a catheter is in anybody, risk of infections goes up, and UTIs are already very common things in this patient population anyway. So let's not do anything where we increase the risk of that. So as far as the ability to stand up a couple of times with minimal assistance to a bedside commode so the catheter can come out if you had one in there, that's a huge thing in this first acute care phase of exercise. First, we want to have them walking, there in their hospital room to the hallway if they can. Everything kind of predicting is where's the next step for this. That's where we work with the entire team. We're going to be with case management, nursing, surgeons, etc. It may not be a whole full team conference, maybe a rehab setting you do, but oftentimes on the acute care floors, maybe there's a huddle. Maybe you're communicating with the case manager, and he or she is kind of like the team captain for everybody and what's going on. Certainly make sure it's in your notes so everybody has what your recommendations are, or a plan, and what's the next stage. Is this going to be home? Is this going to be back to assisted living facility? Is this going to be a long-term care? A lot of times here with acute fractures, even when they're converted, this is a great place for inpatient rehab documentation and making sure you can get them accepted there. And we have a fair number of people that, you have a elective hip replacement, you're not going to really qualify for an inpatient rehab stay. If it's due to a fracture, that can be great, especially if you can document all the way back from the beginning. If this person was living independent, they were driving in the community, they were actually maybe were still employed, they did their own grocery shopping, and now they had this fracture. Those are certainly the criteria that a case manager and a reviewer and insurance company is willing to see documented to justify why is actually maybe an inpatient rehab level of stay is appropriate here, and then 2 or 3 weeks there to return home because they were so independent. It's all those things that start, or we have a role in documenting what could they do, where are they now, and what is actually their prognosis to get back to. And I always like to not shortchange the patient. Err on the side of they're going to work hard, they're going to do well. They want to get back to that level of living. So before we move on to the next phase, I just want to quickly summarize big picture acute care setting. What are some of the recommendations? What are we trying to do here? I guess it mostly comes down to being proactive from the day they come in, from the moment they come in the hospital. Order sets. I mean, ours are in the ER. We get the therapy consults when the person's even still in the ER. We do the best thing we can. Of course, it depends on time and day you come in to see you preoperatively. At least meet with the person, meet with their families, try and get the picture of what did this person look like, what was their ability before the fracture. So we start our discharge planning right there. It's also a great time preoperatively to set the stage for both the family and the patient. If they're in pain, they've got a lot of things going on, but setting the stage of what is therapy, what's the rehab going to look like, that we are quite likely going to be wanting you to get moving day of surgery, or certainly the morning post-op day one. Recommendations are to be up and out of bed, to have meals, so it's not a shock to them. And certainly when our surgeons support that as well. You get people, especially older folks, they tend to still do whatever the surgeon says, he or she. So the therapist comes and we talk to, and our credibilities with the surgeon. If you got your surgeon saying, yeah, I'm gonna do this. Here's how we're gonna do the anesthesia. Our expectation is you're gonna recover fairly quickly, and then that day I'd like you to be moving, sitting on the side of the bed, standing at the side of the bed, and then certainly breakfast the next day, meals. We want you to have meals out of bed. So if everybody is encouraging early mobility, they're talking about you may have a catheter, but we're going to try and get that out as quick as we can. As long as we set the stage ahead of surgery, then when we walk in, because if you've worked acute care very long, a lot of times you walk in the room and introduce yourself, and like the eyes roll and you get the groan, and here's the therapist, and they're gonna make me do all this. But if you get somebody that's already expecting it, that can go a little better. So we're going to focus on with them. Let's do functional things, rolling in bed. Maybe it's a bridge. Maybe it's things, muscle contractions that way. Not just a lot of open chain leg swings. Getting onto the edge of the bed, getting on their feet. A number of studies have been done looking at the main thing to do is to sit to stand motion. Just put the weight on the ground and stand up and sit down, and stand up and sit down. Frequency of this. More is better. Some work I've been reviewing lately. This is from a couple years ago out of Australia. Laura Kimmel did this on a bunch of patients there, and they actually were recommending 3 sessions a day in the acute care phase. Now, again, that's a little different system, and certainly internationally, it's a different focus. They're going to be in the hospital a little bit longer, and they are different things on rehab that has to do with, of course, payers and financial considerations that are made in different systems around the world. But again, higher frequency is better, and get their feet on the ground. We try and do at least BID, and then once a day on the weekends. I understand those are staffing dependent, but understand that even if it's a short session, maybe 20, 30 minutes in the morning, and then maybe 15 minutes around lunch, and then another 15 to 20 minutes later in the day, I would offer that's probably more beneficial here than maybe a 35, 40-minute session, early in the morning, and then the rest of the day they're either just sitting or they're lying in bed. So those are all considerations to make. So now we're moving on to the next phase, and then where is this person going to be going, and then long term, what is this? So healing considerations. You've got the bone, you've got it fixed, the pin, the plates. Maybe if it was a arthroplasty, of course, you don't have to worry too much about the healing because the glue's set there. But talking more pins, plates, sliding screws for kind of those subtrochanteric fractures, things like that. Again, you're dealing with a bone probably it's pretty soft. So typical fracture healing time 6, 7, 8 weeks. You see a new callus formation. It's probably gonna be a little slower here. Of course, weight bearing activity encourages that. Does help with bony growth and the callus formation, new cells coming in. So that's what you're looking there. But of course, the thing is stabilized. It's got pins and screws through it. So we want to get them walking and moving. So hopefully, heading out of the hospital, certainly we made the case for inpatient rehab on the acute fractures as well. But maybe depending on their, premorbid status, functional ability, that's going to dictate a lot of what's happening next. So they're ready to leave the acute care floor. This may be, day 2, day 3, day 4. It certainly varies. Where are we going to next? What's the recommendations? Again, that's based on what they could do before. Erring on the side of let's be proactive and encouraging here and try and get the best outcome. So say we're going up to the inpatient rehab floor. What should happen there? Well, that's certainly medically. This is everybody kind of, I guess, whenever you have a fracture, any kind of injury, we do this, a stroke care, any kind of thing in the hospital. This is where you kind of do a debriefing or a post hoc analysis. Let's look and say, okay, what were the contributing factors here to this? Was it medication? Was it just accidental fall and the fracture? Was it pathological fracture? Was it is it the osteoporosis? What is the bone density? What can we do here going forward to prevent this again? Like I said, we do the same thing with strokes. Anything we have is you kind of look and say, okay, what do we want to do so that this is the only time this happens? What are the diet things? What are medications that need to be on board? Biophosphonates, vitamin D, all those kind of things. Certainly side effects with some of those, and that's more medical side. We actually do recommendations. We have fracture clinics in our Charleston hospitals that we use. I'm at one of our smaller hospitals and we don't. So that kind of falls in the lap of orthopedists and the family practice doctors. Certainly we give them, they get guidance from protocols and guidelines that we have, but it's medication things that can do that. Let's say here we're on the inpatient rehab floor. We'll start using those medications actually on the rehab floor. We have the physicians there that everybody's on the same page, and we can start getting the medicines going, dietary things, and just encouraging that and saying, okay, here's where we need to be with bone density, medications that are going to help you. But what do we as therapists do? Well, we're going to be working screening on what happened here. Was this a balance thing? Is it vision? Is it an assistive device that you needed that you don't want to use, you never did? Was it just an accidental trip? Was it a slip, fall, and kind of go over that and talk with, what's the situation? What do we do to prevent that again? We need to get you better on steps. Is it living conditions, or was it, I often say, was it just purely an accidental one that went down? So the main things we want to do is we want to get strength. We want to get strong butts and strong thighs. We want to be working on reaction time kind of things. Standing, you're going to be in parallel bars, moving, being up on your feet often. I'm not on the inpatient rehab floor. I'm not a huge advocate of a lot of mat exercises for these folks, unless it's just issues with pain and you want to get some mobility. But if we're timing things well, and we always work with the nurses of what time we have, schedules, everything's detailed out. We try and follow as best we can. You want to try and time, okay, what medicines they're getting and when. And if they haven't had the medicine, we have the flexibility to see different people and come back, as you do want to optimize when they have pain relief, because we're going to be exercising and we're going to be doing for that age, that stage of person. This is going to be a fairly high intensity for them that they may not be used to. Certainly they could be older, and so bearing with what is high intensity in this population. And so, it's not the same as you're going to see maybe in an outpatient setting, but you do want to be working fairly hard, get the muscles contracting, doing some steps, stepping up and down, repeated sit to stands. Again, I'm not going to harp on that over and over, but just the ability to sit to stand, to build confidence in that, to build strength. a big predictor in falls that happens, especially after this. And I talk with this with patients I do balance training with all the time. Is that we're trying to build confidence, decrease fear, decrease anxiety as best we can in you. The fear of mobility, fear of a fracture again, or just fear of falling is a big issue here. I think that how do you get over fears that you have? I mean, I talk about, you're afraid of the water when you were young, or when you're afraid of the dark, or how do you do fears? Well, graded exposure. It's how we do it, whether it's with pain, long-term pain management, but how do you address that? How you address chronic kind of issues? Well, it's graded exposure over time to something that is scary. And I always tell them, when we do balance things, I'll let you wobble. I do want to work on reaction time. I will not let you fall, but I am all for letting you wobble. If I'm always just holding on to you, or you're always just, in a harness, or you're always just holding on to the parallel bars and everything's 100% safe, I would offer that you're not really going to be making gains in strength or your ability to balance yourself. And I tell them in a very nice way that we're going to do some things that are going to be a little scary. And I actually want that. I want to expose you to some things that you're afraid of, because that's the only way you kind of can work through those and build a little confidence in yourself. So those are all the overriding things to do. Is you want strengthening, you want to be close chain. Remember to do your dosing. I said it could be your rep max test if you have to do the isometrics and non-weight bearing things. But once they're up on their feet, is then you can do a 10 rep max or a 12 rep max, that kind of thing. Is, how long does it take to do sit to stands, or, how many can you do in 30 seconds? And long term, you get to an outpatient setting. Those are certain strength criteria, and there's benchmarks based on age. And just to give you those, it's most people that are over 70. Long term, what's considered normal strength is they can do 12 sit-to-stands in 30 seconds. So that's certainly a long-term goal, when there's all kinds of benchmarking criteria. Again, for balancing, you'll read different things on, like, what's a normal Romberg balance, and some things will say 30 seconds. For the general population, that is. But as you get older, if you can do a Romberg for 10 seconds, that's good reaction time. Single limb stance, some studies say, the ability to do a single limb stance for 10 seconds long term, that goes a long way in correlating with a lower risk of a fall. Now, certainly some of these people haven't stood on one foot for 10 seconds in probably 30 years, but I think it's something you can work towards. As you get into your more elderly population, that goes down. If they can even do 5 seconds, your fall risk goes way down too. So incorporating balance things can be as simple as Rombergs and single limb stance, in the parallel bars. So other exercises too that you see a lot, and this is more, I guess, home setting, or we do an inpatient rehab, and I of course I do primarily my work as an outpatient, so I usually am catching people further down the road, weeks after surgery, once they're home, something like that, or at least I hope that I do. I guess that's a point here to talk about. A lot of times after hip surgeries, particularly if it's maybe the hemiarthroplasty and the fracture, people are encouraged to, the main thing you got to do is you just need to walk. You just need to walk. You just need to walk. And while I agree with that, it's the most functional thing that the human body does. So many times over my career, and I've seen this borne out in studies, when you get into looking at things of long-term risk factor of falls and even back pain, I often say, I see a lot of people that show up after they've had a hip surgery, a year after the fracture, but I'm seeing them because they have back problems now. And I often can trace that back too, and just doing strength testing on them, as they just never got all the hip strength back. Granted, you've had a fracture, and maybe it'll never be 100%, but they never were pushed. They never were taught how to do exercises at a good dose to actually build strength, and so here they manifest themselves weeks, months, or even a year later, and problems with walking still, their balance is off, and they're showing up because they have a back problem. And so there's often a strong correlation with hip strength and just general low back strength and their back pain. So I encourage early on to dose appropriately and to work on actually building strength in a closed chain way. What else does that look like? So, the classic, standing at the kitchen counter and doing your hip abduction and flexion and extension, all those kind of things. And then I love I go over the people and I say, okay, you've been doing home care here for a couple of weeks, and what are we doing? You've been on the inpatient, what you've been doing, and they stand up and they are swinging their operative leg all over, and they can swing it, and they can do 20, 30. Oh, I've been doing my leg lifts, I can swing this back, I can swing this forward. Look how good this is. And then I said, well, that's nice. Have you ever done it where you actually stand on that leg? Many times they're like, well, no, they didn't have me do that. And so I would encourage you to, the kitchen counter exercises and the sink exercises are cool, but I'm going to spend most of your time standing on the leg you had surgery on. I don't care, even if you can only do, 3, 4, 5 of them, lifting the non-operative leg, that's way more functional. And in the long run it is. So usually that's when I switch them. I say, yeah, you can keep doing that, but let's stand on the other leg. And then they go, that's harder. It's harder. And I'm like, yeah, it's supposed to be. You're not going to be able to do as many, and that's okay. So simple things like that I find that I do have to, I remind people of a lot, whether it's the therapists or the assistants that was working with them, that I find that issue. So fast forward now, maybe we're out of inpatient rehab. We're walking pretty good, maybe with a walker, doing 150 feet, 200 feet, something like that, household distances. You've worked on your stairs, able to go up and down with them. You're getting a little more confidence, and then you're going home. Far too often, that's where the therapy ends, or maybe there is a couple of home care visits. And of course, everywhere in the country, that's limited to time, frequency, sessions. Of course, there's so many factors that go into how we see them, from population density to just geography, where you are in the country. When I used to do home care, I worked in the South Charlotte area, so of course you had. I could see 4 patients within the 2 miles of each other. So you can do a lot more. I certainly am respectful of areas that are more rural than that, and we do work in a rural area around here as well, where it's you might get 4 people in a day because they all live a half an hour apart to drive to each one. So those things are there. So that's where home exercises, education, family, caregivers. Maybe it's somebody that's got a in-home caregiver that's been hired by the family that's going to be with them, teaching all those people. And there's lots of things that can go into this. Actually, a nice study, again, I was looking at the other day out of New Zealand, and it was exactly that kind of a rural thing. And partly this was in hospital, but certainly this would extrapolate over to the home care environment. And it was doing exercises, teaching people who aren't therapists, like how to do it. And they were using nurses, they were using physical therapy students. I've worked with over my career a number of in-home care aides, just helping them to remind Miss Jones here of the exercises, and here's how we can do it, and even teaching them how to do contact guard assistance or simple things like make sure you have a chair behind you when you do this. But there's lots of people that you can encourage and empower to help people with the exercises. And a lot of times here, it's going to be just reminding them. A lot of times the job of the home care aide in the home, it's medication reminders, it's food reminders, it can be exercise reminders. Have you done your couple exercises here? And again, frequency during the day carries over here. Again, I mentioned the studies out of Australia on this one that show 3 sessions a day made a significant change from day one on. So again, what are we going to have them doing when they're at home with this? And I'm going to tell you that higher frequency is still better. Still better. Instead of 30 repetitions once a day, spread that out. And again, we're trying to dose appropriately, trying to figure out what is your maximum, and trying to give you an actual dose of exercise. That whole about 60% of your max, 2 to 3 sets, 8 to 12 times. So maybe that's you get your 3 sets in of 8, but you do that 3 different sessions a day instead of trying to plow through and I got to get 3 sets of 12 in my first session, and then I'm exhausted for 3 days because I'm worn out. Spread those out. Higher frequency is better here, but you want to get that same kind of volume of load. You're working like 3 sets of 12, but spread that over a day. It's certainly more tolerable. Time it with pain medication. So same kind of things we did in acute care, they carry over here as well. To timing, make sure you've taken your medicines. You're going to use ice after it. Some of this stuff is going to make you sore. I'm going to have that discussion with patients about muscle soreness versus pain. The soreness, because if you haven't been active before, some muscle soreness initially when you're doing a little higher intensity, maybe you've added some new exercises, is normal, and it's actually a little bit desirable. and talking the difference. Certainly, we don't want to be increasing the pain they're having. So the talking where it is and kind of getting ideas. It just, is it just in the glute muscles, or is it actually around the groin side? Is it running down the leg? Certainly, we will vary what we're doing then. But a little bit of soreness, I encourage that. And when I talk to them about it, I do it in a positive way. Like, actually, that's good. That's the stimulus to build the muscle, is some of that's going on. Now, if they're remaining the muscle soreness, they've been doing things for 2 or 3 weeks, then I'm probably certainly overdosing them. So I've talked here about dosing of exercise, and I think our bias is we underdose. So be mindful that we don't want to overdose either. I'm not advocating that. I'm not trying to be mean or aggressive here, but I do want to challenge people to push them a little bit, because thinking more in my mind, where are they going to be, in 3 months or in 6 months? I know it's sore today, but what are we going to get when you're down the road? You're going to have more confidence. You're going to walk better. Have less other problems, knee problems, back pain, things like that, as you get further down the road. So how do we incorporate balance training and falls preventions here? And that's where you start again. You do a good assessment. Whether there's tons of ways you can do this stuff that we all have clinically. And now I guess I'm fast forwarding a little bit more into an outpatient setting and long-term falls reduction kind of thing. So we're kind of getting that later phases of rehab, which again, I hope that we see them here. I mean, often here we're in the States, and it's not always standard whether they get the orders or whatever. And, they're doing the orthopedic follow-ups at 1 month and 3 months, and you try and communicate with that group and say, let's not just stop the therapy because they're home and tell them all you need to do is walk, because I think that's incomplete. So hopefully we are working some. This isn't a ton of visits later, but this is just in our general, falls program. And you start with an assessment, whether it's as simple as, the 10-item, the Berg balance assessment's been around for decades, highly validated here. Repeated sit-to-stands, timed up and go tests, gait velocity tests, and actually getting a measurement to work from. So, you have them in the clinic and say, how long does it take, to walk this 50 feet or 100 feet, or what's the distance you can do, but actually have a measurement. So then you can set a goal and work backward to, and share that with them. Say, here's where we are today. If I compare this to the typical, 80-year-old woman in the community, here's the speed. Now, you may not get to, 3.5 meters per second because you're here today and you're walking. Okay, today you're at about, 1.9 feet per second. They go, oh, wow, that's really slow. You go, yeah, it is, but just imagine if you got that to like 2.2 seconds, you need to make a 20% increase. You may never get to be as fast as some other people are, but what's faster or quicker for you? And where that comes down to is a lot of times what happens with the fall with somebody. It's the middle of the night, they've got to go to the bathroom, and they get in a hurry, but they're slow and they get there. Just a simple thing, if we can build a little confidence, increase a little gait velocity, maybe that correlates to, I'm not as rushed getting there because I can move and I get to the bathroom. Or certainly being out in the community, how long does it take to actually, if we're walking somewhere and a light changes, or I'm in a parking lot, how long does it take to get there? So giving them the standards and actually sharing that with them, giving them their timed up and go, here's your score today, here's how this correlates with fall risk. And it's, different ways to look at it, but the rule of thumb I go with, and this is other older research things, is I tell them, this has been done on hundreds and hundreds, if not thousands of people throughout history, and the people that can do this simple timed up and go, if they can get in 13 seconds or less, and then when we follow them for years after we do it, their likelihood of having another fall goes way down, and give them motivation like that. So, hey, today, you did the timed up, you turn, you come back and sit down. It took you about 16 seconds. Let's see if over the next week, maybe we don't get that to 15 and a half seconds or 15. And we're shooting for that goal that we're there. This is the same kind of principle you would use maybe with an athlete or with a bodybuilder. You got a pitcher who's wanting to throw a higher velocity, or an athlete who's wanting to run faster. Well, other than just saying, well, we got to get faster, give them an actual measurable goal and compare them to other people where they want to be. I want to be safe. I want to be confident. I want to have a lower risk of a fall. Well, what do those people who don't fall as often, what do they look like? Well, they have this much strength. They can do a sit to stand, this many times, which the number is about 12. They can do a timed up and go in about 13 seconds, and their gait velocity is more than 3.2 feet per second. I just sent those. If we achieve those goals, your overall just statistical risk of having another fall for mechanical safety reasons is way down, and use that as motivation for them. And certainly there's medications and other risk factors that go with this, and you have to assess vision. I do that a fair number with people, and I'll have them come in for balance training, do a quick vision screen, check their glasses, and I ask them a question. When was the last time that you had your glasses checked? Have you had your cataract surgeries? Things like that. I do a fair number of things. This is kind of a personal thing. My brother's an optometrist, and he does visual screenings, and he does all kinds of things for balance for us. So I really got exposed a few years back to a lot of the impact of the eyes, and different lenses they can use, because we have all these people that have balance, even dizziness kind of problems, and just nothing seemed to be helping. And we trace it back and find out that actually an underlying visual thing is there. Or it's as simple as, if you haven't had an eye exam, in like 5 or 6 years, or when they have their glasses, but you've had the same glasses for 10 years, it's probably time for a change. Get those things incorporated. And I've seen, staggering changes in balance and confidence just by having somebody go to the optometrist or go to see your ophthalmologist, get those things checked. Because, I can have the greatest exercise in the world, but if the underlying thing is vision, or, you have your bifocals on and the line is in the wrong place for you, or the glasses, they don't fit and they slide down your nose, so now the lens is in the wrong place in the angle of your eye, and that's why you don't see well. Lots of things like that we have to consider. So it can be medication, it can be vision. Certainly we do strength, we do reaction time training, things like that. But looking at the whole person, and like I said, we go back to that. Why did this fall happen? We do it's kind of like when you have a crash, or the National Traffic Safety Board shows up and tries to piece together why did this plane crash, and go back, and then we make changes on how to improve that. It's the same thing with the person is, why did this happen? And let's just go step by step. What can we do to reduce those risks? And vision being one of them as well that goes here. So again, that's more your outpatient setting, and being a comprehensive, multidisciplinary. I said the disciplines and include vision, certainly the medical team reviewing medications, cardiologists. Can there be some change in medications or timing or dosing? Orthostatic hypotension is a common thing that causes falls here. We see that a lot. Of course, people they're on blood thinners, they're on anticoagulants, they're on antiarrhythmics, all kinds of things for their heart, and stroke prevention is very common. And sometimes the doses that was working 6 months or a year ago, over time, I tell people that sometimes the medications take with blood pressure, they can start to, as you get a little older, they can start to almost work too well. Or maybe you have had a weight gain or a weight loss, and now you need a dosage of the medicine correction. So certainly, as therapists, we want to be multidisciplinary, working with the team, with everybody that's involved, sharing our notes. I mean, I routinely do evaluations, and I send them, of course, the referring physician. I ask them, who's your primary care doctor? Who's the cardiologist? And I'm going to just do a carbon copy, and of course we digitally send notes over to them, and usually that's appreciated as to where we are. Encouraging people to keep their follow-up visits with cardiology, ophthalmology, vision checks, geriatricians if they have that, certainly rheumatologists if they're there, and people that are doing medication management for reduction. So we're coming close to the end of the time here, so I'm kind of going to do a summary overview again, and just kind of review what I've tried to cover here. I'm going to go back to the outline of the course and kind of hit a few of the highlights here and make sure we've done that. So the original outline was going to do incidence of hip fracture mortality rates. Well, those run at about 300,000 people a year seem to do it. Mortality rates, some of them in the first 30 days, numbers you'll see numbers 7, 8, 9%. Unfortunately, 60 days that goes up to around 15% or so. It's even actually dead within 60 days, which is unfortunate. Usually that's a much more complex medical patient. But again, even that all-cause mortality, if you track them for 1 to 2 years, it's still hovering around 30%. Unfortunately, in these folks, that's usually good for other medical reasons that happens. They just don't get their mobility back. What are the risk factors? Well, it's age, genetic factors, osteoporosis certainly, and much more in females based on body structure, type, race, ethnicity. How do we mitigate those? Well, it's medication, and I'm a big proponent of exercise and strength training, early in life. I recommend that in younger women. I think that osteoporosis prevention and reduction, I think I tell ladies that starts in your teenage years. What you're doing there, what you do throughout your life from diet, vitamin D, calcium, walking, resistance training, incorporating strength training throughout your lives. When these do happen, the acute management of the fracture, of course, there's really no reason to delay the surgery. We want to fixate the bone as quick as we can, and there's multiple options for that. Hemiarthroplasties, total hips at times as well, or depending on the location, it's the pin and screws and sliding screws. All it's intracapsular, you try and do a replacement if it's outside the capsule, or if the bone is just too soft where the hemiarthroplastic components won't work, then you have to use something else. Early mobilization, post-op day 0 if at all feasible, timing acute care things with medications, encouraging meals out of a chair. We want you up and on your feet. The adage you hear sometimes is we want everything out and everything up. We want catheters out, we want IVs out as soon as they can, and we want everybody up and moving. The sooner is better. High frequency therapy. Actually, there's been plenty of research that says 3 sessions a day is great. Two a day is kind of highly encouraged, and maybe breaking those out instead of one 30-minute session, maybe do 2 15 to 20-minute sessions, morning and evening, but mobilizing, standing, getting out of the bed, actually dosing, strength training there, timing isometrics, that kind of thing that I talked about, and come up with the right exercise dose for these folks. The timelines, here in the States, is probably going to be 2, 3, 4 days on acute care, and then possibly to inpatient rehab, possibly to assisted living, possibly back home, hopefully with outpatient therapy. That all certainly is predicated on the premorbid status of the patient. Timelines here, if you have the pin and screws in, then you're looking at fracture healing at 6 to 8 weeks. Certainly that can be extended in the older population if they have softer bones, less density as well. If it's a hemiarthroplasty or a total hip, of course it's glue, it's set, full weight bearing there. You're really not waiting on healing other than surgical site healing, or the posterior incision, or you can do an anterior approach on these as well. If you're doing a hemiarthroplasty, on somebody, go ahead and many more surgeons are making the anterior incision just like in total hips. And of course, recovery timelines when you do an anterior approach are lightning fast because you're not really disrupting a lot of the musculature. So that's there. The long-term prognosis, well, again, there's some factors that aren't modifiable. Gender, you can't modify that, and some genetic components, but certainly you can do some things to try to mitigate that, both medication, diet, and just weight-bearing exercise. And then ongoing fall reduction is actually measuring fall risk and why, whether it's gait velocity, timed up and go, repeated sit to stand, basic Romberg testing, single limb stance testing, or full on if you've got the ability, full on Balance Master electronic things. We have one of those, and the patients like to use those. We incorporate a Wii and video game systems in both our rehab units. Those things have been around for a long time. Looked at many, many years ago, and incorporating a little bit of fun, a little bit of challenge, side-to-side motions, so many kind of things you can use like that. Technology here, even in the home, getting people say, you up and kind of doing like some Wii games. You maybe standing by your walker, but you've got your grandson there helping you. Incorporate some fun into things that are dynamic and changing direction, stuff like that, that you can do for balance training. Again, the big thing there is building confidence. Give them the standards. Here's what we're shooting for as far as your overall fall risk reduction that we want to achieve. So hopefully that's been helpful. Enjoyed the time together. So there's hip fractures, trying to do that in an hour, and it's a broad topic, trying to hit on a lot of different things here. Tons of resources out there. And I encourage people always to look at things all around the world, different healthcare systems and things they're looking at, because the human body is very much the same physically around the world, whether you're in Australia, New Zealand, Canada, across Europe, parts like that. That it's great to learn from other systems and what they're doing, because the body heals much the same way when it's bones and muscles. We have a lot to learn from each other and different systems. So I always encourage that. So thank you.
Thank you for listening to the PT and OT Connection podcast by Summit Professional Education. To view accreditation information for your state and profession and access completion requirements to receive a certificate for completing this course, please visit summit-education.com or click the link in the course description in your podcast platform.